Good morning, ladies and gentlemen. My name is Inoka Wimalaratne, and I'm one of the psychiatrists from Wimalaratne Hospital. So I just want to introduce you to my study, which I'm doing in New Zealand and in several other countries. And the study is on cross-cultural comparison of general hospital specialists' attitudes towards psychiatry. And as you can see, culture seems to be a theme in today's presentations. And here I'm looking at the culture of our healthcare force, our doctors, which is another aspect of culture, I suppose, and how it influences us. And I'm doing it under supervision of David Menkes, who's here today, and Graham Millsop, and Sarah is joining us as well in this study. So my rationale for the study, I think you all agree that there's significant physical comorbidity among patients with chronic mental illness. According to this WHO report in 2013, in patients with major depression and schizophrenia, 40 to 60% have a greater chance of dying prematurely compared to the general population. So that's very scary, and you know that mental illness is on the top of the list of variables associated with physical health inequalities. What about physical or psychiatric comorbidity in the general hospital patients? That's very common as well. According to this Danish study in 2001, 40% had a psychiatric comorbidity. And we can think of several reasons for this. If you look at the prevalence of depression and anxiety among patients with chronic medical illness, the increasing number of self-harm, suicidal patients, medically unexplained symptoms, and hospitalization itself can cause, psychological distress. So how does this affect, or how does it affect outcomes? We know that psychiatric comorbidities are associated with poor prognosis among the general hospital patients, increased mortality, morbidity, functional impairment, loss of productivity. According to a British study done last year among heart failure patients, they found that having a psychiatric comorbidity increased the length of hospital stay by 3.3 days. There are several other studies which have come up with similar findings. So if this is the case, what about psychiatric care in the general hospital? I work in a consultation liaison psych department, and my own experience, as well as if you look at the literature, you can see there are several gaps. Lack of screening, under misdiagnosis, lack of referrals to psych services, and delays in treatment. So if you look at these kind of gaps and you wonder why, I think you have to kind of look at attitudes of health professionals towards patients with mental illness. And I wanted to look at doctors specifically because ultimately doctors are responsible for treatment decisions, including referrals to psychiatrists or psych services. And doctors do have differences in their attitudes when compared with other health professionals. So I also wanted to look at attitudes and underlying factors and wanted to break it down into several layers in order to explore it further. So you can kind of look at attitudes from an organizational point of view, systemic factors, patient factors, and the clinician factors. Systemic factors, organizational culture, policies, legislation. Patient factors, what sort of diagnosis the patient has. Does it matter whether the patient has schizophrenia or depression? Clinician factors, you can see like professional experience, speciality. We know that there are differences between surgeons and physicians that have been found in previous studies. What about our own personal experience with mental illness and our own cultural background and experiential beliefs about mental illness? And things like gender and age. If you look at this diagram, you can see culture stands out at all these levels as a significant factor. So my objectives were to look at general hospital specialists' attitudes towards management of psychiatric problems and assess the associations with the cultural setting that they practice in, their own cultural identity, and some other variables. So we selected several countries of different cultural mixtures, backgrounds, and used a tool that had been validated in Britain before. And it's a self-administered questionnaire. So we wanted to maintain confidentiality. Of course, we are looking at people's ethnicity and religion and cultural variables. And we also wanted, the preferred method of data collection was an online survey, but in some centers, as you can appreciate, this wasn't feasible. So we had to rely on hard copies. And of course, we had to translate to other languages and make sure the validity was maintained. We selected the minimum size of 100 per country. This was based on previous studies that used the same tool and the sample sizes they had used. In order to get 100, we had to send it to at least 500 people, given that in this type of surveys, the usual response rate is between 20 to 40%. Ethical consideration, we submitted it to Health and Disability Ethics Committee, but of course this was not a interventional study or didn't involve any patients, so we didn't have to go through a full review. But we got local ethics committee approval, and consent was implied by participation. This is the progress so far. So you can see some countries have become champions in terms of exceeding the minimum number of responses that we needed, like China and Netherlands. In other countries, we're still in early stages, but it's progressing. In China, we did manage to analyze the data. I do not have time to go through the details, but overall, the results reveal that there's widespread positive attitudes among Chinese non-psychiatric doctors, but they do identify need for more time, more access to psych services, and professional support. So now we eagerly wait for findings from other countries in order to compare. So my request for you today is, and I'm not sure how many non-psychiatric SMOs are here today, but please participate in the survey. There is a table desk that you can go and fill the questionnaire online or on the paper during the lunch break. And I thank you for your participation in advance.